endometrial compaction, or what is endometrial compaction, and how is it associated with frozen embryo replacement success rates using euploid embryo. So basically, this is a recent publication in the month of May, so a few days ago, by this group led by Zilberg et al. And it's in fertility sterility. And I thought that's a very interesting publication for everyone to have a look at. So again, going back to basics, that for a normal healthy pregnancy, we require a normal euploid embryo, receptive endometrium. And we have talked quite a bit about endometrial receptivity and sensitivity in the last meeting and the one before. So this is pretty much a continuation of all of that. One of the commonest reasons why early pregnancy loss happens, well, more than 80% of the time, is due to the aneuploidy of the embryo. So chromosomal imbalances, abnormalities lead to a pregnancy loss. Therefore, we think that there is a role of PGTA which can contribute to increased chances of live birth. Though there have been several recent studies being published which basically think that PGTA itself is not an absolute be it and end all. It can be effective in certain group of people, but it's not that fantastic as what we thought. Almost 40% of IVF in the United States are PGTA cycles. So you could see that how aggressively PGTA has been marketed and is being used as well. So what is the role of endometrial thickness and the pregnancy outcomes? And I think Dr. Goody spoke at the last webinar on Saturday, that endometrial thickness itself is not absolutely the crucial factor, and there are many other factors responsible. And I've just made up slides of relatively recent publications in the last 10, 15 years about the role of endometrial thickness. And I think it would be very interesting for you to actually read through some of them to say that whatever concepts that are sort of flying around at the moment, where do they come from? So the least investigated aspect of endometrium is the compaction of endometrium in the luteal phase. What compaction in simple English or in simple term means that decrease in thickness of endometrium in the luteal phase at the time of embryo transfer. So we always keep focusing about 7 millimeter trilaminar endometrium, but we never talk about what happens once you start progesterone, how the endometrium goes through the subsequent changes. And if you have a trilaminar endometrium present at the time of transfer, that's not good enough. You need a reduction in thickness of endometrium. Endometrium needs to start becoming non-trilaminar, and that is one of the crucial aspects. And this is what this publication tries to look at. So there were a couple of studies which found no correlation, and reputable authors like Barker in about 10 years ago, and then again Greisinger in Germany in 2018. But Haas and the group, which is also a part of the same group that this publication comes from, showed significantly increase in pregnancy rates when thickness decreases between the end of estrogen phase and the day of embryo transfer. In that particular study, they did not focus on euploid embryos, and therefore they decided that a next study that they would do, which is the one that we're going to discuss, should be a little bit more focused. It should show positive correlation with pregnancy outcomes using embryo morphology and compaction as criteria and multivariate analysis. So this study is focused on frozen embryo replacement cycles, and we all know that frozen embryo replacement cycles have gone up quite quickly. A lot of us have moved towards majority of our transfers being frozen replacement cycles now. Euploid embryos via PGTA have very used, therefore removing the variable of chromosomal status. So you're trying to basically eliminate as many side things as you can and focus just on the endometrium. And the hypothesis is that compaction in progesterone phase or luteal phase would correlate with increased pregnancy rates using euploid embryos at embryo transfer, thus supporting the earlier study, which was in untested embryo. So let's see what this study shows. So materials and methods devised a single center observational study. 234 frozen embryo replacement cycles were included. So not a small number, reasonably good number of cycles. A single euploid embryo was transferred. They performed ICSI for all cases. Assisted hatching was done on day 3 to assist trophectoderm herniation on day 5, 6. So they wanted to maximize the chance of embryos getting up to blastocyst. Now, that is not, I have to agree, a routine practice for majority of the clinic, but this particular clinic did assisted hatching on day 3. Then the biopsies were performed of trophectoderm on day 5 or 6, therefore placental cells were biopsied. They were then tested and embryo was vitrified within 1 to 2 hours of biopsy, followed by NGS to do the PGTA. So this is what they used as their strategy. All cycles were HRT cycles for endometrial preparation. Progesterone started once endometrium was 7 millimeter or above, just like what Anil had mentioned in his last talk, and trilaminar. So 7 millimeter was the cutoff here. Progesterone was used as progesterone in oil, intramuscular or vaginal route. Transfer was carried out on day 6 of progesterone, which is standard. Grading by experienced embryologists using the American SART grading as proposed in 2013. Endometrial thickness was recorded on the day of transfer, and operators were blinded to the pregnancy outcome. Primary outcome was ongoing pregnancy, which is OPR, with fetal heart at 12 weeks or later. And the statistical analysis was used with students' t-test and logistical regression with multivariate analysis. So pretty robust methodology at performing this study. Results were based on statistical analysis. Compaction rate of 15% was considered significant. Ongoing pregnancy rate was 51.5% with this as compared to 30.2% if endometrium did not compact. So that is the first difference that they noted. There were no differences in age, BMI, etiology of infertility, and about 29% of patients achieved 15% compaction. So almost 1/3 of patients, or just below, managed that 15% compaction criteria. Even those who achieved 5% compaction, or 10% compaction, 15% compaction, and 20% compaction, so they basically looked at the others, then how much compaction happened, all resulted in a significant increase in the ongoing pregnancy rate. So 15 was just picked up by that, but even those who showed even 5% compaction rate showed increase in the ongoing pregnancy rates. And multivariate analysis showed on difference in age, BMI, endometrial thickness at the end of the estrogen phase, but showed significant positive influence on the ongoing pregnancy rate with PGTA tested embryos. So again, it's quite important to look at the parameters that they used to come to some sort of conclusion. What's the indication for PGTA? Well, in our practice, it is not indicated for all. Recurrent implantation failure of 3 or more embryos, transfers with good quality embryo with no pregnancy seems to be the reasonable cutoff for most clinics to go down the route of PGTA. If patients have had recurrent pregnancy losses of more than 2 early pregnancies, then that can be used as a cutoff as well. Overall compaction rate of 29% in this study group, as we mentioned. Recurrent implantation failure, 11.4% in the compaction group of patients, and may point towards underlying etiology in some cases of RIF. So patients who had RIF or recurrent implantation failure, who have had multiple failed transfers before, did not seem to achieve good compaction. Why is that? We don't know exactly, but there is obviously something going on at the endometrial level. Advanced maternal age, so patients over the age of 37, patient requests, because some patients would request that I want to have PGTA, and others where in cycles where surrogacy was performed, male factor infertility was performed, or PGTM was performed in the smaller number of cases. I don't know why these little lines are coming up on my presentation, but anyway, I hope you can still see. So main objective was to assess the compaction of the endometrium and its effect onto the ongoing pregnancy rates in frozen cycles of euploid embryo, as we mentioned before. even with PGTA tested euploid embryo, morphology scores were still taken into consideration. And it seems that morphology still is an important factor when you choose your embryos. So if you had 5 PGTA tested embryos, which are euploid, which ones will you choose to go back into the uterus? Well, you then go back to the morphology of the embryo, grading of the embryo as per your lab gradings, and then transfer that single embryo. So 2018 study by Liu et al. Had shown in over 19,000 embryo transfer cycles, which are all frozen cycles, that OPR and live birth rate decreased significantly for each millimeter it should be, below 7 millimeter in FER group. And therefore, keeping 7 millimeter as a cutoff seems to be a reasonable thing to do based on that data. It was also calculated as a difference of endometrial thickness rather than just a single measurement between estrogen phase and start of progesterone. Failure of compaction seems to be due to inadequate response to progesterone. And I think that is where a lot of discussions are now going. And as Anil mentioned, that there's going to be a webinar tomorrow about measuring progesterone levels on the day of transfers and how adding additional progesterone can rescue your luteal phase. So probably it is inadequate response to progesterone that leads to failure of compaction. And when you address that by increasing the dosage or duration of progesterone, or even decreasing the estrogen dosages or switch to modified natural cycles, then you will start to see that perhaps we might be able to improve the compaction rate. So changing compaction, if you notice that there is not adequate enough in your clinical practice, you may have to use one of these variables, i.e. either reduce the dose of or increase the dose of, reduce the dose of estrogen or increase the dose of progesterone or duration of progesterone, i.e. you give it for 6 days and transfer on day 7, or you move to a modified natural cycle rather than an HRT cycle. The other interesting thing was that recurrent implantation failure subset was a very interesting group of patients in this bunch of study. And these are the group of people where we think that the endometrium does not respond very well to progesterone. So whatever you do, and therefore, you know, a lot of you ask questions that, oh, I've transferred euploid embryos, after euploid embryos, I've given so much progesterone. Why does this patient not get pregnant? Well, here may lie your answer that whatever you do, that endometrium in these group of patients is just not playing the game. And that is where the role of surrogacy might come in. So this is just thinking off the top of your head, that what strategies and plans should you make? So let's look at, with any study, when you critically analyze it, you need to look at the strengths and the weaknesses of the study. Because I often see in my practice that people quote a study and say, this study says this, therefore I'm going to change my practice. No, 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 no. You need to look at the study, look at the positives, negatives, and then decide, should you change your clinical practice or not? So if we go by that concept, it shows that this has got a relatively large number of cycles. As I mentioned, 234 cycles were included. There is a standardized HRT regime. There is a standardized endometrial cutoff of 7 millimeter. We know that the independent assessment of scans, images by 3 experienced operators without the knowledge of pregnancy outcome were done, so they were double-blinded. Use of PGTA was sort of applied to test the euploid embryos and transfer elective single embryo transfer. Therefore, this study is pretty strong in its design, i.e. focuses mainly on the endometrium. But every study has its weakness. And what is the weakness of this study? That this study used transabdominal scan at embryo transfer rather than a transvaginal scanning. And we all know that transabdominal scanning sometimes is not as accurate as TV scanning, and therefore Anil and I are moving slowly to doing quite a lot of our embryo transfers under TV guidance. The other downside of this study was that it's a retrospective observational study, and that there is operator-dependent bias at the TV and TA scans. But that has been kind of countered by the review being performed by 3 different operators. So where does this take us now? Knowing what we know, that compaction seems to be an important aspect at the outcomes of a cycle, what we need to now start looking at is to how do we manage the cycles that fail to compact? And I think that is going to be a very crucial thing. It's all well and good to know that, yes, these people don't compact again and again, but why is that? We may need to use newer protocols for endometrial preparations. Like I suggested, that often we tend to move from HRT regime to natural cycle or modified natural cycle replacements, and they often may give you a better outcome. We also need to assess now next is what is the role of endometrial compaction in fresh cycles, because there is now some data on the frozen embryo replacement cycles, but would it work the same way in a fresh cycle? And what would be the role of endometrial preparation in modified natural FER cycles? That would be the next step to look at as well. And then in one of my talks that I had mentioned that we need to start looking at the molecular mechanisms of these various genes, which may be underlying reason why compaction fails. So in conclusion, I would like to say that compaction of endometrium seems to be a vital ingredient at improving ongoing pregnancy rates in FER cycles. This may be a relatively easier and efficient as well as a low-cost method to improve OPR because it's not based on a tremendous amount of laboratory-based technology. This is what we do every day in our clinical practice. We prepare patients, we scan them, we decide when to transfer the embryo. And perhaps the process studies need to carry out, which often people always say this should be done, but this group has already started doing prospective studies to validate these findings a bit further. So I'm not saying that this is the new best thing, but what I'm trying to say is that try to focus in a group of people where you don't get enough success on how the endometrial compaction happens. Thank you. I will end my presentation there, and I will get to stop the sharing.
Just one question, Amit.
Yes.
Dipan Thakkar, who says, did they cancel the transfer when the compaction was not seen?
No, they got on and transferred the embryos, and because they're trying to compare that what is going to happen in non-compacted group of patients.
Okay.
Okay. Anil, can I go ahead with my share screen?
Yes, yes.
So hello everybody, and I'm going to discuss with you about the use of heparin or LMWH in our IVF practice. I think a lot of us have seen these prescriptions, a lot of us have given, but let's go into the evidence, what evidence we have and how do we discuss about this LMWH usage in ART practice. Obviously, most of us will first, whenever we see implantation failure, will rule out other etiological factors for implantation failure. And then after ruling out all the etiological factors, we'll say, well, the working diagnosis we keep it suboptimal endometrial receptivity. And we all understand in our science that angiogenesis, an invasion by fibrinolysis of the syncytial and cytotrophoblast into the endometrium, is one established fact of implantation and placentation ahead. And obviously then heparin or LMWH comes as a logical choice to all of us. So this is one paper published in Fertility Sterility on immune modulation treatments by Nick Macklin, who's done quite a bit of work on the whole of endometrial receptivity, selectivity, and implantation process as such. And I think this is very practical thing that most of our patients always keep telling us that, well, do something to improve implantation. And that's a very assertive demand of most of our patients. And there could be a competitive commercial context. We don't want to leave the patient alone, and we want to put something. And even the client is interested in putting some new treatments, experimenting with new treatments. Once there is a complete information given to them about the advantages and the disadvantage, at least there is no side effect profile that is explained to them, they're willing to try some new treatments. And this compelled many to fill the gap between the clinical need and the scientific rationale by empirical treatments. And I feel, patient is, and us on the other side, they feel like a doctor is a weather forecaster or a meteorologist, and they want us to predict their success. And we are telling them, well, I am a scientific person. I'm going to improve your success. I'm not going to predict the success for you. And whenever you keep reading about the immune therapies and you go through all the literature, it's quite a depressing read. Because so many therapies are there, so many tests are there, and we really don't know which test is available. And we tend to go with aspirin, steroids, interlipids, heparin, and that's one of the Hippocratic ways of practice, and a lot of commercial interest come in the way there as well. Well, studies are many. There are many studies which have been there, and they have been conducted very well. There have been randomized studies also conducted. They are published in most of the high impact factor journals. Uh, but we should remember that recurrent implantation failure or recurrent miscarriage is not a clinical diagnosis. It is a clinical presentation, and there could be different factors responsible for this clinical diagnosis, clinical presentation. Uh, and implantation failure as such, we understand it's quite heterogeneous. There could be many reasons like hydrosalpinx, embryo aneuploidy, thin endometrium, endometriomas, adenomyosis, old age, etc. So we all rule this out. And then we have to come to a reason, is there a cause for the suboptimal endometrial receptivity? And we really get stuck there. We really don't have a particular cause. And then we keep attempting different therapeutic options. And the science keeps telling us that it is not a precise therapy and it's not valid either. But we don't get convinced. And we said, we understand it's not precise, but we just hope with our patients that it could be a valid therapy and more of a value-based practice. And that's what we follow in our practice. When it comes to APLA and thrombophilia, and these are the battery of tests which we commonly do. I'm sure any one of you have been adding any test, you're welcome. But this is the kind of test which is there in yellow color, which we do in my practice. And we must go back and understand the 2014 task force on APLA syndrome. And they revised the Sapporo criteria for making an APLA a syndromic diagnosis. And what they added in this revision was the APA positivity's reading should be beyond 40 GPL. You know, the reading comes, the reading should be less than 12 to say that it is negative. And the reading is 16, and we believe that it's positive. No, it should be at least 3 standard deviations more to say that this patient is definitely having an APLA positiveness. And this positiveness should be persistent with 2 tests done 12 weeks apart. And how many of us really practice this particular, because this is quite an expensive test. And we wouldn't be doing the whole battery of tests 3 months down again, just to establish that fact. And the different mechanisms in which the APA syndrome affects the implantation process could be thrombosis, as we understand, preventing the thrombosis, but it definitely may be making a difference to the oocyte quality and the uterine decellularization itself, and we'll talk about it in a short while. And the whole concept of prescribing LMWH in implantation failure has been borrowed from the use of LMWH in unexplained repeated pregnancy loss, isn't it? We all just borrowed this. But what does this study published says? That this is a meta-analysis and systemic review. It says, well, it doesn't make a difference. When you talk of LMWH in unexplained repeated pregnancy losses, it is not making a difference. That it is not saying that it is something which is very clinically significant and should be very relevant either. And this is as late as 2010 publication. So the fact we have borrowed it from a very faulty premise of use of LMWH in repeated implantation failure. One more question let's ask ourselves is, does ART increase the risk of thrombosis? We understand, we keep aside the other fact that a lot of our women could be PCOS, diabetes, a lot of high body mass indices, and they would be having a risk of thrombosis per se. But otherwise, the process of ART does it increase the risk of thrombosis? And this is a nice publication in Human Reproduction in 2012. And this is about the Danish National Cohort Study. And they clearly say that there is no evidence that assisted reproductive technologies increase the risk of thrombosis. And the interested reader can go through this publication. And but whenever we do ovarian stimulation, there is a rise in estrogen level. And this rise in estrogen level could be like it is a procoagulation stage. There are 2 different views on this procoagulation state because of a rising estrogen level. There have been people who say that, well, the estradiol level goes very high and there is a risk of venous thrombosis, and even upper extremity deep vein thrombosis has been reported in patients taking ovarian stimulation, and the pathophysiology being the thoracic duct gets a lot of estrogen to the upper extremities. And I'm sure a lot of venous thromboembolism episode which might be taking place during the IVF protocol may not get reported for the interest of the doctor. Again, there are few doctors who say that, well, the estrogen levels are very high, but they are natural estrogens. We talk of the estradiol levels, or we give a synthetic estrogen to the patient, and then the chance of thrombosis will go up. But will the natural estrogen going up, will it just increase the chance of thrombosis? No, so there are 2 sides of the story. But there are again established fact that we do use LMWH in certain risk situations like OHSS or patients who have SLE or APLA positivity. And if there is a history of thrombosis and that patient is going for an ART, I'm sure all of you are using LMWH in practice. Let's talk about the APLA syndrome and infertility and APLA syndrome and implantation failure. What does the literature say? When it comes to APLA syndrome and infertility association, it is not known if APLA causes infertility or it is just merely a serum positivity. And it has also been noted that APLA increases in response to pelvic damage. So a lot of our patients could be having endometriosis, pelvic infections, or they've undergone some pelvic surgeries, and the APLA serum titers would be high. In one of the studies, they reported that 23% of the IVF population was showing an APLA positivity compared to an 2.5% of the antenatal population. Now, when we talk about a relationship between APLA and the implantation failure, there is one group of studies which say that, well, there is an association of APLA positivity and implantation failure. And there are studies which also say that, well, there is no association. And the Hornston et al. In 2000 have published a meta-analysis of all the studies of association of antiphospholipid syndrome and implantation failure. And they say, well, there is no association. But thrombophilia is being seen in unexplained infertility patient, but there's not been any association with implantation failure. Now, how does APLA can affect implantation? We have understood about the thrombosis, but they said there could be a direct effect on the embryo and it could affect endometrial deserialization. But if we assume this is correct, then whether the subcutaneous LMWH you give, how it really affects the free floating blastocyst in the uterus and how it can exclusively act on the residual development, and that's really not known. Science is not giving any evidence in that context. Now, when we talk about a few studies about women with APLA positivity and IVF failure, what the studies have done is they have grouped the acquired and congenital thrombophilia and even MTHFR gene mutations in the one whole group of thrombophilia disorders. And this study by Sharif, they had about 21 cases of APLA positiveness, and implantation and clinical pregnancy rates improved after giving LMWH. And the studies by Kublan et al., and they had about 83 women with 3 IVF failure and 1 thrombophilia test positive, and they gave 40 milligrams of enoxaparin, and they did notice a significant increase in clinical pregnancy rate. What about IVF failure women without any thrombophilia test positive? And this is one study which is done by Urman in 2009. This is again an RCT, about 152 women, and he gave enoxaparin 1 milligram per kg body weight till 12 weeks from the day of oocyte retrieval, and they did notice an increase in the clinical pregnancy rate and live birth rate, but not statistically significant. But actually, this whole data of Urban, they needed actually 350 cases to complete the study, and number of embryos transferred was not mentioned. There was no control group. Moreover, when we went through the study, we realized that it is a GnRH agonist protocol, long protocol. It's a fresh embryo transfer and cleavage stage embryo transfer. And all these 3 things are not practiced by us, most of us in today's era. And again, none of these studies followed the Sapporo, revised Sapporo criteria. The correct methodology of antiphospholipid testing was not mentioned there, and no repeat testing was done either. So it was just by a single testing, all these studies were conducted. So basically, the evidence is becoming weaker and weaker. Stanwell in 2012, he had about 594 ART women. They compared to a fertile population and women with no history of venous thromboembolism, and like patients who are having your factor V Leiden and protein CS, and they said that factor V Leiden and protein C, protein S deficiency do not have any relationship with this ART outcome. Again, no association with MTHFR carrier status as well. This is one beautiful study by Buckingham et al., and this is published in Human Reproduction in 2006. And what it did, there are only 3 studies in the literature which are mentioning about doing the APLA antibody testing in the aspirated follicular fluid. Believe me, it's a very difficult thing to do because most of the time the follicular fluid will be contaminated with the maternal blood. So you will have to really get a neat sample of follicular fluid which is not contaminated, and then you do an APLA test. And they proposed that these antiphospholipid antibodies could be binding to the oocyte. And as the embryo develops, this embryo, just because the antiphospholipid antibody is binded to the oocyte, this embryo could have a defective genome or it may not grow well. and this could be having a defective quality, and that's how the APL syndrome can affect an ART outcome. But then they possibly put forward that APL positivity is just a transient epiphenomenon of ovarian stimulation. That one moment you start doing ovarian stimulation, the seropositivity of APL goes up. So now let's look at the studies, the intervention studies of using LMWH, and let's start on a very positive note. This is one study by Lodigiani, published by low molecular weight heparin in women with repeated implantation failure. It's a retrospective observational study, and see the difference in the clinical pregnancy rate. 17% in women not treated with LMWH and 29% in patients treated with LMWH. And in women, especially who are beyond 36 years, and this is one group probably all of us may be using LMWH for the prevention of thrombosis reasons, the clinical pregnancy rate with LMWH is 35%, while non-treatment is 15%. And that's quite appealing. Then what are the different meta-analyses? There are about 4 meta-analyses which have been published on the usage of LMWH in this particular group of repeated implantation failure. Let's go through them. And this is meta-analysis by Young et al. About the use of low molecular heparin in IVF and ICSI patients in non-thrombophilic women. This meta-analysis, they said that LMWH has no effect on ART outcomes in non-thrombophilia group. And as you see the Forex plot, that is pretty clear there. Cochrane in 2013 did have a publication on heparin usage in assisted reproduction, and they clearly say that there is unclear evidence that whether peri-implantation heparin improved pregnancy rate, and the evidence does not justify the routine use of heparin in recurrent implantation failure patient. And what they put up in the discussion was this fixed effect model of meta-analysis and the random effect model of meta-analysis. In the fixed effect model, in this model of meta-analysis, you assume a particular effect like heparin directly improving the implantation failure rate, just have one result there. And when you analyze as per that result, then probably the studies say that RCTs say, well, they hold true. But when you say the random effect model, where you have the population is varying, like in the fixed effect, it is the variation in the sample size is the only factor which is different in the different studies. But as we know that can be true in most of our studies. When we start comparing the studies for meta-analysis or getting the data set together and start analyzing, we realize there are more differences than just the sample size variation. There could be differences in many more confounders. So most of our work also, we are not seeing the same kind of patient again and again. We see different variations of patient in a group together. So the meta-analysis must talk about a random effect meta-analysis giving a good positive result. And that did not, that positivity was not confirmed by this Cochrane study. Sheshadri has published a study in RBM Online in 2012, again a meta-analysis. And she again says the same thing, the randomized study, there's no significant difference in pregnancy rate. There is a high heterogeneity. But when you talk of observational studies, there is definitely an improvement in pregnancy rate when you use LMWH. And this is a study by Neelam Poddar in Human Reproduction Update. This is one of those highly quoted studies. But the whole study has 3 main papers. One was the Kublan in 2008. As I said, one of the problems that they grouped all the thrombophilia into one group of Apla syndrome. And again, repeat testing was not done. When it came to, and they all used 40 milligrams of enoxaparin. And when it came to a study by Urman in 2009, he gave 1 milligram per kg body weight. Now, there's a difference. In Kublan, it was a fixed dose of 40 milligram. Probably all of us are following that particular regimen. But when it comes to 1 milligram per kg body weight, a 65 kg woman will end up having 65 milligrams of enoxaparin. So that's a pretty high dose than our routine practice. And when it comes to another study published by Berger, this was a Posse randomized study. It was not a perfect randomization. There was no blinding. And most important in this particular study, the AMH, AFC, and FSH itself was not recorded. So there are some inherent weaknesses of the study. But the meta-analysis did say that there will be 8 women need to be given LMWH to get that 1 extra pregnancy. But the result was the miscarriage rates were low, but routine use of LMWH was not recommended at the end of this meta-analysis as well. And these are the different RCTs. There are almost 6 RCTs published on the LMWH use. And these RCTs say only one RCT is talking about it is being useful. The rest of the RCTs say, well, giving LMWH in patients of implantation failure is of no use. So what is the conclusion? Probably the evidence of heparin in use in IVF is pretty weak, and a subgroup will be beneficial, and that subgroup will include women who are young, there are 3 or more failed attempts of embryo transfers, and there is at least one thrombophilia test positive. But most important, no study has been done with antagonist protocol and no frozen thaw embryo transfer cycles with LMWH supplement. So we really need to generate quite a bit of data on this thing. It's the evidence which needs to be generated. Now let me shift to aspirin. Uh, with aspirin, I'm just going to have 2 slides on aspirin, and a Cochrane review is already there on aspirin usage in IVF, which we are very well aware about. And this is a publication which talks about the aspirin is aspirin effective. And this is a publication after the Cochrane and all the meta-analysis has been published. And it was an individualized patient data meta-analysis, wherein 4 meta-analyses were chosen. And 3 of them, they are concluded already that there is no statistically significant result. And one meta-analysis by Roop et al. In 2008 said that there is a statistically significant result with usage of low-dose aspirin in implantation failure. And what we mean by an individual patient data meta-analysis, wherein the study authors are invited to collaborate and share their data sets, and all these data sets are accumulated and a summary data set is created, and then that is analyzed. And in this particular study, only 60% of the authors contributed to the data set and 40% did not contribute to data set. So again, that is one of the weaknesses of this particular study. And the conclusion was that aspirin does not improve pregnancy rates in IVF, and Cochrane has really said the same thing. So I think this is one thing which we should not be practicing. Rather, every individual meta-analysis has pointed out to certain ill effects of aspirin, barring the bleeding and the PPH, etc. But they have said that probably aspirin group, the treatment group, did have more number of preterm deliveries, and that's something to be kept in mind. As it is, we understand our IVF patients are at risk of having preterm deliveries. On top of that, adding aspirin, if it is going to increase our chance of preterm deliveries, that we'll have to be very well aware about. So these are a few unanswered questions. Will all RIF benefit with aspirin and LMWH? Which subgroup of thrombophilia disorders will really benefit? Which heparin? Because the WHO says that every heparin is a different drug. You can't have the your fragment and enoxaparin. You cannot have a comparison between that. There are 2 different drugs, will have 2 different effects. What dose, optimal starting time, what is the duration of therapy, alone LMWH or aspirin? These are the different unanswered questions the literature is not throwing light upon. So the European world has decided to wait for this particular trial to be published. And they said, well, RCT is difficult to publish because RCT is going to require more than 1,200 cases. And it's very difficult in the real life scenario to collect that much cases for RCT to do. And that's why they said, let's go by the real treatment protocols. And this was initiated first in Greece, wherein they just took a survey of the Greek consultants and how many of them are using LMWH in their protocols and what is the style of using it, what dose and what are the cases, what are the indications they're choosing. And then they decided to take design 2 registries. And one of the registry is about observational studies on reproductive outcome of women with recurrent failures and spontaneous assisted conception. And this is an observational study on anti-thrombotic prevention of thromboprophylaxis in pregnancy losses called Otilia. And any patient who's commencing the new ART cycle, they are calling it a first. It's a part of the first study. The title of the study is first. And the study is from 2012 to 2020, so it's getting over now. And obviously, they will be waiting for the live birth, which is another 1 year they'll have to wait. And after all the live birth data is there, this registry may throw a light in which subgroup of patients, women, the LMWH made a difference. And probably we'll have to wait for these results to be published. I love this author, Roila Orvito. And I think, Anil, we should have one session on all the publications of Roila Orvito's. And they're very interesting, very clinically relevant. And there's a huge benefit from these publications. And this is just a case report. And this is, this is a common question comes to every IVF consultant, that the patient in front of you has attempted 2 or 3 cycles, have undergone 3, 4, 5 embryo transfers, and you are stuck and you want to know how to plan your next cycle. And here is a nice way Orvito has done it. He says that we'll consider the embryo factors like better pregnancy with blastocyst transfers and frozen embryo transfers. So that we will freeze that we will do these 2 things. And we will do an agonist and antagonist together. So we will go an agonist protocol, so agonist stop protocol, and then we'll use an optimum dose and give an antagonist. Then we will use a dual trigger with HCG and leupride because we want to have a maturity of the cytoplasmic maturity and good nuclear maturity. We will do a blastocyst frozen thaw cycle, do an endometrial scratch, natural or modified cycle, natural transfer cycle, HCG, progesterone, GnRH agonist from day 4 of the embryo transfer. Now, this appears like a masala treatment, but believe me, a lot of people in India, a lot of consultants everywhere who are in their private practice could be wearing this hat of practice, and they're not bold enough to come to people that, well, this is what I practice, and I'm hoping to get a better pregnancy. And I really admire this author that as a case report, at least he has gone ahead and published, said that, well, this is what I feel we should do. Well, thank you so much, and I would like to end here, and Eid Mubarak, everyone, all of you. And if you have Kheer Sharma, remember me.
Okay, any questions?
So, Anil, are you using heparin?
Me, no.
No.
I think I continue to think its role is in preventing deep vein thrombosis. So I'm not entirely certain about its role in improving implantation.
Okay.
Yeah.
So there's a question Deepan is asking that in which cases should we use heparin? Preferably not, is not much use. But unless you have done a thrombophilia testing, all the battery of testing, and at least you notice a positivity of that, or the patient who is giving history of previous thrombosis, or again you go for syndromic diagnosis, follow the Sapporo criteria, where the patient has at least previous 2 episodes of obstetric outcomes, which are 10 weeks, and placental insufficient, unexplained placental insufficient, all that is noted. So consider all those factors, and probably if that patient is going for an IVF protocol, probably yes, you may try it out.
And sir, do you use in those patients who are going for oocyte donation cycle, who are around 40 or 42 year of age?
Yeah, I think that age, yeah, that's what that's a different set of indication. That is where you're using for the age, her obesity, and as a preventive measure, and she is on to a synthetic estrogen for a long time.
Yeah.
So that could be one valid reason of usage there.
Yeah. And which dose do you give in your practice? Routine 40 or 60?
In these obese women in that particular group, ones who are receiving, who are recipients, I just give 40 milligrams of enoxaparin.
Thank you, sir.
Well, I would slightly differ is we have to, if you're treating something logical, you have to decide why are we treating the person. If you're treating the person for deep vein thrombosis, so for example, a lady whose BMI is more than 40 or 45 and goes for a cesarean section, you do thromboprophylaxis to prevent DVT, and that's a completely different indication. So in the same way, I think if we think this lady is at the risk of a deep vein thrombosis, but equally, if you think this lady is at a risk of deep vein thrombosis, why should she be donating eggs? And I'll put that question.
No, he's asking about the recipient.
The recipient, sir. Recipient.
So why would you give a recipient too? So let's look at the here's somebody who's
many times the recipient could be 40 age or obese or something like that.
Because in the UK, the cutoff is a BMI of 35. So for a collection or may it be for transfer of embryos, and that's the cutoff. But what's the recommended cutoff is around about 30. So the NHS, you can't treat anyone over a BMI of 30. And that's because the evidence that comes from obstetrics is quite a damning evidence on complications that occur in pregnancy.
Okay, thanks.
And Amit, are you really looking at the compaction now after this publication? Was it your practice to look at the compaction?
No, it wasn't before, but we've been thinking about it for a little while because it was an observation that when you actually do the embryo transfers and when you do the scan, and this is going back even 10, 15 years ago, you never could see trilaminar endometrium. And nobody actually at that stage looked at it, or nobody actually spoke to me, even my bosses, and say that, oh, the trilaminar endometrium should disappear because of 3 or 5 days of progesterone. It was something which you question yourself. You think, well, why does the endometrium not look trilaminar? When you're very junior in your practice, that's the question you ask. But no, there was nowhere to look for and no one answered it. So actually, if you start thinking that I don't use it, and I was answering to someone that there is no cutoff as such of, oh, this patient has got poor compaction, therefore I'm not going to transfer. That is not the point that we are at as yet. We haven't yet gone that far. But what we do seem to know from observation that if you do not change your patterns from trilaminar to progesterogenic endometrium and it starts getting thinner, what you measure, let's say 9 millimeter before you started progesterone, and now it is still 9 millimeter and looking estrogenic, then perhaps you may need to start thinking that should I actually be transferring embryo in this case or not? So I think that is what I think we're not there yet, but it is a clinical observation now. How effective it will be, and I think that is why they've started prospective randomization now. That should we do transfer? Should we not do transfer? What will we do? Who goes in which arm? Yeah.
And how should we measure, transabdominally or transvaginally?
Well, I mean, majority of the transfers are till transabdominally because that's what everybody does across the world. A lot of Spanish clinics have now gone down the route of TV transfers. And I think I did not do transvaginal transfers for checking compaction, but the reason why we started doing them sometimes in retroverted uterine group of patients where filling up bladder does not help because it makes it more retroverted. If you don't fill up the bladder, you can't see anything anyway. So that's where doing a TV scan assisted transfer does help, but it takes a little while to get hang of it. It's not as simple because there are too many things fiddle around. With abdominal scan, there is a nurse holding it or an assistant holding it. Here you are the one. So you need to get your head around it a little bit better.
But as we start measuring compaction in all cases, even on the day of studying progesterone and on the day of transfer, so we should follow only one method. Like, so generally on the day of adding progesterone, we do a TVS. That's why I was asking.
Yeah, no, I understand.
So to make a measurement,
it's a good suggestion.
Transabdominally,
Before we actually set up for transfer, we could do a TB scan and see what the endometrium is like, because then you've got like with like comparison. I completely understand. It's a very good suggestion. I might start doing that. Thank you, Deepan.
Thank you.
Yeah. That is why these evenings are important. We all learn. Anil, do you do that? Have you started doing it now?
No, I think Deepan made a good point. I agree. I think what we do is that we do a transvaginal scan, and many of our transfers are done transabdominally. So a measurement of embryo transfer is not like to like. I only do transvaginal transfer when it's a retroverted uterus, where I think I can see it more clearly and it goes better. But I think that's a very good point, is you can't measure compaction by transabdominal route, or rest of your measurements are by transvaginal route.
Yeah. And that was one of the drawbacks of that study, as if you look at the weaknesses that I pointed out, that, there are two different methods. So I think that's a good point. We should start doing that. So it doesn't take that much longer, right? It doesn't take more than 30 seconds to do a scan. Yeah.
True. Yeah, Deepan.
Can hear.
Yeah, sir, that was, thank you very much for the suggestion.
Okay, thank you all. Thank you so much. Nice to see you all.
Yeah.
I think next week I'm doing a talk on FOI, which is a follicle oocyte index, and
Yes.
those parameters, which will it's a bit more understanding into how recruitment of follicle takes place, and what do we understand when we have 8 follicles get 2 eggs, and what does that tell us about the ovary, and all those concepts which are slightly which are old but which have come back into form.
Good. Thank you, sir.
Hello. Bye bye. Take care.
Okay.
Bye.
Thank you. Bye.
Bye.